And we continue with the pilots now, this time with kidney disease. Joining me live on stage here in Best is Dr. Klemens Budde, the head of the Department of Nephrology and Medical Intensive Care at Charité Hospital, and also Dr. Roland Roller, who is a project manager and researcher in the Speech and Language Technology Group for the German Research Center for Artificial Intelligence. Gentlemen, the floor is yours.
Yes, and thanks. And we were going to present the kidney pilot. And as you know, kidney disease, or first of all, our participants and our partners, and I think we really put together an extraordinary consortium with two university hospitals, the University Hospital Charité and in Essen, health insurance company, the largest one in our region, the German Research Center for Artificial Intelligence with Roland, and the Hasso-Plattner Institute, a high school or education institute and research institute for artificial intelligence. And kidney disease is an important factor in the global population around. We expect 10% of patients having kidney disease, and kidney disease is expensive. And although only 0.1% of the population are suffering from complete kidney failure requiring dialysis or transplantation, it is really accounts for 1% of the total health expenditure in Germany. And as you know, kidney transplantation is the method of choice. It has a lower mortality, better quality of life, and lower costs. During the kidney pilot, we got a really excellent cooperation with a health insurance company, and we were able to really look into detail for the costs for patients before transplantation and after transplantation. And as you can see on the slide, before transplantation, you have much higher costs, especially outpatient costs in light blue. The transplant year, of course, is expensive because you have to have a high hospitalization cost. But then all years after transplantation, you have much lower costs compared to the dialysis before transplantation. However, in green, you see hospitalization costs are still relevant and need to be addressed in order to get better costs and better quality of life for our patients. And our vision is quite simple. We want to connect the patient with the treating physician. And in order to do this, we established a telemedicine with remote patient monitoring to detect complications early and reduce hospitalizations. And for this, initially, we have to develop a dashboard which was integrated into the electronic patient record. And as you can see here, the patients are able to document the blood pressure, the weight, and the well-being in order to present the data for a telemedicine team, which then can review the data all the time. However, again, the data which are sent by the patients, someone has to check the incoming data, and for this you need a telemedicine team in order to improve outcomes and then, in fact, reduce hospitalizations. We established during this kidney pilot a telemedicine team, and in the meantime we served more than 370 patients after kidney transplantation with telemedicine care. And as you can see, patients transmitting every day their vital signs, weight, temperature, blood sugar, or well-being. And over this 1.5 years we are doing this, a huge amount of number of data have been accumulated. More than 250,000 data were transmitted by just 370 patients. And so we encounter, of course, a problem with big data now, because we have a large number of incoming data and the time-consuming communication. And in order to address this problem of overwhelming data inflow, we need specialists for data and in order to have a better handling of incoming data and better manage those data who are really important. And with this, I would hand over to Roland, who will look into this in more detail.
So Klemens was introducing the telemedicine system, which was actually directly introduced at the beginning of the pandemic, January last year. So it was technically the right moment. So now I would like to give a brief overview about what we did on top of it. So there were basically three main components we worked on. So you see kind of the cycle, which represents the network of Charité and the telemedicine system. Then it communicates to the patients outside. So first of all, we were working on adherence monitoring and outlier detection. This was kind of in between the telemedicine system and the patients itself. So monitoring the incoming data streams. Then we were working on natural language processing. We developed a toolbox to process German clinical text. This was within Charité based on the clinical notes and the discharge summaries, which were already in Charité. And then what I would like to present now in a bit more detail, kind of a nice additional piece is the risk prediction we were working on. So at the beginning of the project, so this is now a longer story of the last probably 3 years. At the beginning, we were sitting together, what would we like to do? So we wanted to do some risk prediction, but what can we do? What is meaningful here? So we came to the conclusion that we would like to do kind of death-censored graft loss, rejection, and infection, and we wanted to predict this within the next 90 days. But then when we defined these goals already, various questions came up to my mind, like how good does a system actually needs to be, and how good can actually clinicians solve this? So, I mean, how good does my system need to be useful for the clinician actually? So that's the big question. And earlier in this session, I mentioned already the lessons learned, and this is a kind of lesson I learned or we learned in our project. So while I'm talking the technical language, maybe the medical staff, the clinicians don't know really what I talk about. On the other hand, the clinicians talk about things I totally don't understand, and this is important. So we need to talk the same language. So this is an iterative process. You need to have a lot of meetings in order to understand each other. So I certainly need the input of the clinicians in order to solve this task. I need the expertise here. So just to give you a brief overview, we use in order to address this task, we use the T-base data. So T-base is a large, in my words, it's a large kind of database of patients in the nephrology at Charité. It includes patients of the last 20 years. It includes demographics, medications, diagnosis, visits, including vital parameters and hospitalization. So there's a lot of data out there. And we created a cohort out of more than 1,400 patients with more than 100,000 data points. So one data point is a moment in the patient's life. Of course, the data is still, it's a good quality, but it is real data, so it is noisy. It's unbalanced. The endpoints we address, I mean, luckily they do not occur very frequently, but this means you have a lot of kind of negative events, and you want to predict certain events which are very infrequent. So this is a kind of a challenge from a machine learning perspective. And then we started working with some kind of typical easy models. So we used gradient boosted regression trees, thinking, okay, later we can throw more complex models on top of it. Overall, our model uses more than 1,200 features, and the modeling itself got more and more complex working with the data. So here again, various learnings out of the project, like the data has a bad quality. There are a lot of missing information. We had to kind of make the system work. Actually, a colleague of mine from DFKI had a server. So we need to work within the infrastructure of Charité. So we decided to take our server and put it into Charité. I think now things have changed, and there are kind of powerful computer clusters there, but at the beginning of the project, we were working with our own hardware, and we kind of inventorized it into Charité. Or like the cohort selection is something like an iterative process you need to do with the people which know about the medical domain. Then, yeah, working on this topic, you sit there as a computer scientist, you develop your model, you evaluate it, and you get some results. Great. So here are some example results of a 5-fold cross-validation using AOC ROC score. Yeah, it's a score, but yeah, one learning here is comparability. You develop your model, and hardly anybody did something similar like this. So this is a problem. So there's a paper from Esteban. They did something similar, but they're working with different data. So how do you know that your model is actually good? And so this is a big problem in the community, and I'm happy to talk about this later in the Q&A session. But yeah, another learning is AOC ROC is just a score. So you can have a score of 80, 70, 90, whatever. It depends on the complexity of the task, and at the end of the day, you would like to know, is this actually useful you're doing? So we decided to go a step beyond the kind of retrospective cross-validation. So we planned a study. We came up with a kind of dashboard. So here you see the dashboard of one single patient, and you see the graph, and it shows the risk score over time of this patient. So over time, so you see the red arrow, which is the latest moment right now, the current moment. And you see in the past, so slowly there's an increase in the risk score. We also got this kind of traffic light system. In the green area, it means there's a lower risk that this event occurs, and in the red area, it doesn't mean the risk, the event will certainly occur, it just means there's a higher probability. So we created this dashboard along with various relevant features of the model, which are now not shown, but just so that you get an idea of it. And then we started a study. So the study AI versus medical doctor versus AI plus medical doctor. So as you could imagine, this is much more time consuming than running a retrospective cross-validation. So for this reason, we selected 120 data points. We included 8 different physicians, 4 junior and 4 senior physicians. Each physician received 15 data points. And yeah, I mean, this is a long process here, and you need to go to get the you need to ask the ethical board whether you're allowed to do this, and the workers' union actually, or workers' council actually said, yeah, but you need to give the doctor 30 minutes time to examine these data points. So you see, it takes a lot of time to run this. So we had 2 rounds. One round, only the medical doctor is solving this task and should do an estimation how likely it is that the endpoint occurs, each of those endpoints. And then in a second round, we reassigned the data points, and we provided the dashboard you've seen before first, and then after that, the doctor should do a new estimation. So there are, of course, various learnings, a lot of learnings here. But let's come to the results. So this is a study which is still under review right now. If you're a reviewer, please accept our paper. So first of all, we were very lucky. I was very lucky about the outcome. AI performs medical doctors. So that was, from my perspective, if you work so long on this topic, I was very happy about this. But then it gets even more interesting. So we see junior physician outperforms senior physicians, makes actually sense. Then the junior physician increases in performance in terms of AOC ROC in comparison to junior without AI support. But at the same time, and this is very interesting, the senior physician decreases in performance when the doctor receives the AI support beforehand. Another interesting finding was the medical doctors are all influenced by the decision of the AI system. And the medical, right. So I think this is quite interesting and maybe useful for future work. So medical doctors and AI detect different patients at risk. So the overall goal is to detect critical patients beforehand and to support the physician. But there are some critical patients which have been only detected by medical doctors, and on the other hand, there are critical patients which have been only detected by the AI system. So for future work, we need to kind of combine this. Yeah, that's from my side.
Yeah, so at the end of the day, we had a lot of achievements, as you can see. So we established telemedicine, we did the study, we did cost analysis, you saw, we did this prediction model. We have now granular cost data for kidney patients. We made another prediction model for dialysis risk from health insurance data without clinical data. We established a database. We had, with Roland's help, a lot of work for the blueprint. We got some prizes and awards, but most important, we had some happy patients, and now we established the doctor at home. Thanks a lot.
Brilliant. Thank you guys very much. I have time for one question, which I'm going to ask you. As a medical profession, as a practicing medical doctor, if you step out of your role in the program and you just, yeah? How did you experience it?
I think we have to learn, and this is the lesson from Roland's study, that we have to learn, or doctors have to learn, how to work with this AI program. And the senior doctors were confident in themselves, and they didn't trust the AI. They said, okay, I'm right, I'm a doctor, I know it. And I think we have to learn also from the doctor's perspective what is Roland is telling us and how he can help us.
Fair enough. We have time for one more for you, which is, what were the technical challenges in all this, especially in this period? And I realized you were going through a lot of data and there was a lot of context, but give us a short feeling for what you went through. What were the pains?
I think the time. So as a computer scientist, you just want to train your models, and that's it. You want to increase performance. But in reality, if you work with real problems, it just takes much longer. It takes time to get into the problem, and you need the interactions with the experts. You can't do it without. Actually, you can do it without, but it's not so meaningful. And also just to make something which might have an impact, it takes time. The study was so valuable, but I mean, we just finished it, I think, at the beginning of this year, and yeah. So, yeah.
Brilliant. Thank you both so much. We appreciate it. As usual, we'll have a short break before we continue on to the next pilot. Thank you, everybody. See you soon.